Okay, let's go ahead and go through this as a group here. Another round with Frank. Okay, so all these case studies are kind of the same in the fact that we get a little story at the beginning and then it asks us to list his symptoms and all that kind of stuff. So let's just go through. And Frank's driving home from work, and he eventually gets in an accident. But what kind of symptoms was he? What kinds of symptoms was he experiencing? I'll start us off here. He felt tired. Definitely focusing. Let's just, before that, his hands began to shake. Trouble focusing on the road. Blurriness. And so his eyes got blurry and he couldn't see what he was doing when he was driving. He slipped off the road and he hit a tree. And then, so those are the physical problems. And then his wife showed up. And what does his wife ask? First thing, were you drinking again? Okay, so a little history with Frank. See, list Frank's physical problems. A question I was thinking about throwing in there was, what do we know about Frank's lifestyle? What do we know about Frank? What's that? That's a good way to put it. He doesn't really care. Okay. Drinking soda, history of drinking, all that type of stuff. And I'm almost, tempted just to throw this question out too. What do we speculate about Frank's condition? Because, really we can't really say a whole lot, but we do know that his eyes were blurry and that he slipped off the road. We know a little bit about his lifestyle. So is there anything we can kind of piece together to maybe explain what's going on? Yeah, I mean, type 2 diabetes is kind of where you go to when there's a lot of sugar involved and stuff to that effect. So, potentially. So he goes into the doctor, and the doctor basically gives him an explanation about what happened. Well, let's back up a second. Okay. So he goes and sees the doctor, and the doctor's an old college buddy. And what does the doctor ask? Have you managed to cut down on your drinking and smoking? So again, history of drinking, lifestyle stuff, smoking as well. I still smoke occasionally, but I've cut down on the drinking. And what was he eating and drinking the night when he went home? Just the typical stuff. Stopped for a couple candy bars, refill of the large soda. Is it diet soda? No, he doesn't drink that stuff. This is Frank. He's okay. He's good. So how's your vision now? His vision now is fine. But he did do a fasting blood test, blood sugar results. So what does that mean, a fasting blood sugar? Yeah, you don't eat or drink anything for 12 hours, come in and get your blood sugar taken. And these are normal blood glucose values. And what are Frank's values like? They're high. He's hyperglycemic. And then interestingly, they also took blood insulin values. They're the blood insulin values. And what are Frank's blood insulin values like? Low. So he's got high blood sugar and low insulin levels. Okay, so that's an interesting piece of the puzzle there. And so the doctor goes on to explain what he thinks may have been going on with just the blurred vision. And I learned this with this case study, but apparently excess glucose can be converted to sorbitol, which is basically sugar alcohol, and that can accumulate in the lens of the eye, and that can cause some blurriness. But the point is that the high blood sugar caused the cause the conversion to the sorbitol, and that causes blurriness.
So in diabetes, troubles with vision, is that because lack of glucose to the brain, or no? Like lack of energy into the brain?
Yeah, I mean, that's a good point. If you're hyperglycemic, but your cells can't use the energy. And so, yeah, that definitely could cause some mental fatigue and stuff to that effect. Once you get deeper into type 2 diabetes, what's the problem with that? Well, you have high blood sugar, and that's damaging the capillaries of the body. And so if it damages the capillaries that feed the retina, then that can cause vision issues. All right. Does that sound like a reasonable explanation about the blurry vision and stuff? And it kind of starts to bring together the blood sugar stuff, stuff to that effect. Let's see. Question 1 here. What hormone is responsible for decreasing blood glucose levels? That's insulin. Which gland secretes this hormone? Pancreas. And what specific cells within the pancreas? Beta cells. And then I like this because we're thinking about diabetes, high blood sugar. And so it's worth a revisit to look at some of these variables. But this is awesome. Here we go. Okay. So here we have a type 1 diabetic, and here's a type 2 diabetic, both pre-diabetic and full diabetes. And we want blood insulin levels, and we want insulin sensitivity, high, normal, or low. For a type 1 diabetic untreated, what would a type 1 diabetic's untreated blood insulin levels be like? High, normal, or low? They'd be low because the beta cells got attacked by autoantibodies. What about insulin sensitivity? Normal. Yeah, there's no reason to think that would be anything but normal. What about pre-diabetes? If you are a type 2 pre-diabetic, let's start with the one below. How's your insulin sensitivity? It's low. That's what makes you a pre-diabetic, is that insulin sensitivity drops off. And let's see, what about your blood insulin levels? Blood insulin levels are high. And why are they high? It's trying to compensate for not taking sugar into the cells. It's like, all right, it's insulin sensitivity is low. We're not getting sugar to the cells. Let's just pump out a whole bunch of insulin and see if we can have some effect, get some sugar to go from the blood into the cells. And then if you are full diabetic, what are your blood insulin levels like? They're low. And why are they low? Because if you're a full diabetic, your beta cells have burnt out. Okay, so low to none, maybe. And what's your insulin sensitivity like? Low, unless you've done something to improve that. So if Frank is a diabetic, which we're like, okay, maybe that's the case. What would you imagine that he would be a type 1 diabetic? There is some adult onset of type 1 diabetes, but typically it comes along in adolescence, and that's something that you figure out because of the symptoms. But why is it possible that Frank is a type 1 diabetic? He did? Of diabetes?
Yeah.
Okay. Of type 2, I presume.
He
didn't say. Okay. Okay. What are Frank's blood insulin levels like? They're low. So that does correspond to type 1 diabetes. So potentially, is it likely? No, just because he's, an older age. If he's type 2 diabetic, which maybe we suspect more because of his lifestyle, would he be a pre-diabetic or a full diabetic? He'd be a full diabetic. Good. And why would that be the case? His insulin levels are low. Now, is it possible that Frank just cruised through this whole pre-diabetic, diabetic thing and was just unaware of it the entire time? I don't know. Maybe, I guess. What do you guys think?
Stressed out. For some reason. Doesn't care if he goes to the doctor, it seems like.
Yeah, so maybe he's just blown off all of this stuff. Although, if you're type 2 diabetic, then again, your brain's not getting sugar. You'd have the polyuria, polydipsia, polyphagia, those 3 polys that we talked about. He doesn't seem to have any of those, or at least that he's expressed. Maybe that's a good question to ask. So anyways, if Frank is suffering from untreated diabetes mellitus, what is he suffering from? It'd be type 2 full diabetes, or potentially type 1, but most likely full type 2. And why do you think this? Well, we have the low blood insulin. We have his lifestyle. And we also have hyperglycemia. So at this point, it'd be good to follow up on some of those diabetes tests to see if that's where we're going. All right, so what does the doctor say here? This is not good. Both your high sugar intake plus the work-related stress, which can cause excess cortisol secretion. Okay, he's stressed, right? Long-term stress, hypothalamo-adrenal axis kicks in, producing cortisol. What does cortisol do? It raises blood sugar by breaking down proteins and stuff. High blood sugar like yours suggests diabetes mellitus. I know this problem runs in your family. At this point, I usually send my patients to take a glucose tolerance test, but you're going out of town. How about we set up this test for when you come back? What is a glucose tolerance test? So you start off by fasting, right? You fast for a while, then you go into the doctor's office, and what do you do at that point? You drink a known amount of glucose. And then you get blood tests every hour, half hour. So if this is time down here, and this is blood sugar, and let's say these are your starting levels, and that's where you drink the glucose drink. Maybe after a little while, those values are going to go up. And in a normal, healthy individual, what should happen to those values after like hour and a half, maybe a couple hours? They should start going down. And why would they go down? Because your body's producing insulin and your cells are responding and it's bringing it down. But if those values stay high, then that suggests that your insulin sensitivity is low and maybe you're not producing insulin. So Frank goes on his business trip. I'm sure he was a real pleasure to hang out with. He comes back. Stacy picks him up at the airport. How were your meetings? It was intense. I'm exhausted. More layoffs. Okay, she reminds him that they have a glucose tolerance test first thing in the morning. What are some new symptoms that Frank has going on here? He's feeling miserable. He's not really hungry. Persistent stomach ache. Now, he says stomach ache, but anytime somebody kind of points to the abdomen, they're kind of like, oh, I have a stomach ache, right? But what quadrant is the stomach in? Upper left quadrant up here. So unless he's specifically, upper left quadrant, then maybe it's something different besides just a stomach ache. So he goes to bed, wakes up in the morning, and Stacy is shocked. What's the matter, Stacy? You look like you've seen a ghost. Stacy brought him the pocket mirror so he could see for himself. What's going on? Forget the glucose tolerance test. We need to go straight to the emergency room. Why is that the case? He's jaundice. And what does jaundice appear like? Yellowing of the skin, yellowing of the eyes. Exactly. So what new physical signs or symptoms is Frank exhibiting? Well, he's got that, I'll put quote, stomach ache. Okay. And also not hungry. And he's jaundice. Okay. What does the doctor see in Frank's eyes that indicate jaundice? Yellowing. Okay. What molecule is responsible for Frank's jaundiced appearance? Bilirubin. Biliverdin gets converted to bilirubin. Yeah, but in the blood, it's bilirubin. Okay, so jaundice is caused by excess bilirubin in the blood. So now we want to determine what is causing this, what's causing it. And there's 3 different categories that we can kind of lean into as far as jaundice. There's prehepatic, there's hepatic, and there's posthepatic. And I guess it'd be worth reviewing this now. But here we have the life cycle of red blood cells. They're produced by red bone marrow. They circulate in the blood for 120 days, but then because they don't have organelles, they can't repair themselves. They start to die. Why is that a problem? Because we don't want all this heat. We don't want red blood cells breaking down and all of these millions and billions of hemoglobin molecules circulating around in the blood. They can block capillary beds and do stuff like that. So where do we go to properly dispose of these red blood cells and the hemoglobin? The liver and the spleen. Okay. And what happens in the spleen? Well, that's a lymphoid organ. It's made of those reticular fibers, and there's a bunch of macrophages on those reticular fibers. And those macrophages are going to break down those red blood cells. What do they do with the plasma membrane? So at this point, we can either recycle or get rid of the components within the red blood cell. What are we going to do with the plasma membrane around the red blood cell? Is that something we can recycle or we need to dispose of? We'll recycle it. Okay. And then we get into the hemoglobin molecule, and the hemoglobin has 4 globin chains. What are those globin chains made out of? Proteins, amino acids. So what are we going to do with those? Are we going to dump them in the trash, or are we going to recycle them? We're going to recycle them, just like dietary amino acids. Yeah. And then we have this heme group that's associated with each of the globin chains. And right in the middle of the heme group is iron. What are we going to do with iron? Get rid of it or recycle it? We're going to recycle it. Okay, treat it just like dietary iron. But then we're left with this carbon ring structure. Once you take that iron off, that heme group becomes what we call biliverdin. And biliverdin immediately gets converted to a molecule called bilirubin. And what is bilirubin? It's a pigment molecule. It's a yellowish green pigment molecule. Anything else I want to go over right now? So when it comes to jaundice, like I said, we can divide it into prehepatic jaundice, hepatic jaundice, or posthepatic jaundice. And prehepatic jaundice just means something's going on before the red blood cells even reach the liver. Okay? Even reach the liver or the spleen, I guess, to be broken down. And what are some things that can cause that? Well, anything basically that causes red blood cells to break down in the blood is going to potentially cause jaundice, because then you have all this hemoglobin being released. It's all being processed by the liver, this abnormal amount of bilirubin. So anything that breaks down red blood cells, mismatched blood transfusions can break down red blood cells. Sickle cell anemia can result in the breakdown of red blood cells. Other autoimmune diseases where you're attacking these red blood cells can all result in that. Then we have what's called hepatic jaundice. And hepatic jaundice is basically just anything where something's the matter with the liver. And the liver is the problem, and that's causing the bilirubin breakup. And then, or accumulation. And then post-hepatic is anything downstream of that. Okay. So when the spleen, there's two forms of bilirubin. There's unconjugated and there's conjugated bilirubin. If you do a diagnostic test, they're going to measure both of those levels, conjugated, unconjugated, in the blood. After the red blood cells go to the spleen and you produce bilirubin, and that bilirubin is released into the blood, is that conjugated or unconjugated bilirubin? That's unconjugated bilirubin. Okay. Then, so here's unconjugated bilirubin coming from the spleen, and it goes to the liver. A hepatocyte is a liver cell. What happens when it gets into the liver cell? Well, it gets converted, conjugated with glucuronic acid, and that causes it to become what we call conjugated bilirubin. And remember, we want to get rid of this bilirubin from the body. So the liver conjugates it. And what's the point of conjugating it? What does that do? It makes it soluble. And just to get to the bigger game plan here, we want to get rid of this bilirubin. This bilirubin molecule is no good. And it's in the liver. How is the liver going to do that? Through the bile duct. Where does the bile duct secrete its product? Into the small intestine. And at that point, how can we get rid of it from the body? Through the feces. How do we get rid of things from the body? We can sweat them out. We can breathe them out. We can urinate them out, or we can poop them out. All right. And that's how we're going to do that. So if you want to determine if you have pre-hepatic jaundice, you could take blood, spin it down, and do a complete blood count. And what would you be looking for with a complete blood count that might indicate pre-hepatic jaundice? What about the hematocrit? A low hematocrit. Your red blood cells are being broken down, and so it's less of the total volume of blood, low hematocrit. If you want to look for hepatic, you can do liver enzyme tests. Do you want liver enzymes to be found in the blood? Maybe a small amount. But if you have liver enzymes in the blood, they do this if they want to check for a heart attack as well. They'll check for heart cell enzymes in the blood. What does that indicate if you have, let's say you have liver enzymes in the blood, you're positive for liver enzymes in the blood. What does that indicate? Why is that not necessarily a good thing? It implies that the liver is damaged, the liver cells have broken down, and then they've released those products into the blood. So it indicates damage with the liver. Yes. Hematocrit. Well, hematocrit, like when you do your complete blood count and you have the plasma up top, you have the buffer in the middle, and then you have all the red blood cells down below. This is 100% of the volume of blood. And the hematocrit is the percentage of the volume that's represented by red blood cells. So 45% of the total volume of the blood is represented by red blood cells. That's your hematocrit. If it's less than that, you have a low hematocrit. And let's just skip on to the post-hepatic. And we'll say you'll do an ultrasound in the abdomen region for a post-hepatic. What might you be looking for with an ultrasound in the abdomen? Tumors or anything in this region that's potentially preventing bilirubin from getting in from the liver into the small intestine. And that could be a tumor that's blocking it up here. What else could you see up here that might be blocking it besides a tumor? What about some gallstones? What if they block the bile duct type of thing? Okay, good. All right, let's cruise here. So fill this in. You guys can do all that. Do you guys think this is excessive?
Yeah. Yes.
Okay, I was thinking about taking it out for next quarter. It's not that bad, but it is easy. Yes, you guys are doing all this. This is for next quarter that I'm potentially doing that. Yeah. The guinea pigs are every quarter. You guys are benefiting from the previous guinea pigs. Yeah. Yeah, totally. I don't get them as Word documents. They give me as PDFs.
Oh, I always post my notes.
Well, that's fine if you want to convert it, but it's hard to do that. I understand. So, yeah. Okay. Anyways, let's move on. Let's keep going here. All right. All right. So we look at his blood results for bilirubin, and here's the unconjugated levels. How are his unconjugated levels?
Oh, sorry.
Unconjugated levels are normal. What about his conjugated levels? Conjugated levels are high. Does that indicate, if conjugated levels are high, does that indicate prehepatic jaundice? If you have prehepatic jaundice, your red blood cells are breaking down, all that hemoglobin goes to the spleen. The spleen is going to be producing abnormal amounts of unconjugated bilirubin. And that's not the case. So it's maybe not prehepatic. If it's hepatic jaundice, would you expect high levels of conjugated bilirubin? Conjugated bilirubin basically is saying that the liver is doing its job, right? Its job is to take unconjugated and conjugate it. So the liver is doing its job. So that would steer me away from hepatic jaundice. And what that steers me more toward is post-hepatic, because the liver is doing its job, but for some reason that conjugated bilirubin is not leaving the body. Okay, is level of unconjugated within normal range? Yes. Where is conjugated form? The liver. Is it within normal range? No, it's elevated, it's high. Yeah, I might take this one out too, this diagram, but you guys can do it.
Nice.
Do high levels of conjugated bilirubin indicate pre-hepatic or post-hepatic? We're going to say post-hepatic. And so we're going to do some follow-up tests here, and then he goes into a CT scan. And if you remember from anatomy physiology 1, this is a CT scan. You're in a supine position. You're laying on your back, and it's a transverse section, and it's an inferior view. So if I'm laying on the table right here, you take a transverse section and you're looking upwards, inferior view. So that's what we're looking at here. How do you know that?
How do you do that? How do you get that picture in that angle? Like if
They
you're
sit on a
laying
table and then they go into the, and then they take the scans, and then this is what comes out.
I did it, yeah, like this doesn't make any sense, like unless they're traveling my body.
Oh, how do they find that cross section? Yeah, that's the magic, of the whole thing. So anyway, so he's laying on his back. How do you know that? Well, here's his vertebra. There's his spinous process. This is the right side with the liver, left side with the spleen. What do you think that VC stands for? Vena cava. What do you think that AA stands for? Abdominal aorta. GB, gallbladder. Okay. And this is a normal, healthy individual. And you see some black spots here. That's gas. But then we look over at Frank's, and what the doctor is concerned about is here's the pancreas, which starts on the upper right side and descends across the to the left. And we have these dark blobs on the pancreas. His gallbladder is big, isn't it?
So is the spleen.
Good observation. So is his spleen. Okay. Speculate on the dark blobs in the pancreas here. Tumors, potentially tumors. Do you think that these dark blobs could affect the secretion of insulin? Yes. By doing what? That wouldn't affect the secretion of insulin.
Oh, sorry.
Yeah. How could an enlarged pancreas affect the disposal of bilirubin from the liver? How could an enlarged pancreas or tumors on the pancreas affect the disposal of bilirubin? Those tumors could block the bile duct, in which case you would get conjugated bilirubin from the liver would back up into the bile duct, into the liver, and then seep out into the blood. Yes. And there's no plunger to take that guy out.
Yeah.
So what's causing Frank's jaundice? A tumor, which is a pancreatic tumor, blocking the bile duct and causing bilirubin to back up into the blood. And is this pre-hepatic, hepatic, or post-hepatic jaundice? Post-hepatic jaundice. Frank also had pale stools. Do they fit with this diagnosis? Yes, because that bilirubin is converted to urobilinogen in the large intestine, and that's a brown pigment. That's what gives your feces its brown coloration. This bilirubin molecule is pretty interesting because it starts off with the heme group, which is red. It gets turned to bilirubin, which is green. It gets turned to urobilinogen, which is brown. So it just gets converted to these different colors. And then some of that ends up in the urine as well as urobilin, which is a yellow color. Why does Frank have hyperglycemia and low blood insulin levels? Why do we think he has low blood insulin levels? We haven't rectified that yet. That tumor that tumor could be affecting the secretion of insulin. And remember, we talked about pancreatic cancer. There's two types of pancreatic cancer. One is called a neuroendocrine tumor. And if you have a neuroendocrine tumor, what would you expect his insulin levels to be like? Elevated. The other type was pancreatic ductal adenocarcinoma, more commonly just simply referred to as pancreatic cancer. And what happens to insulin levels in that case? They go down. So not only does Frank have these tumors, but potentially he has pancreatic cancer. And based on what you guys know about pancreatic cancer, what's the prognosis for that? Not good. Low survival rate. Low survival rate. Yes. Back to the CT, yes. The stomach content here?
Yeah, like it's fine there, but then on the other side, it's like, it looks like those skies, like a flood sky.
Tough to tell. I wouldn't be able to. You'd need somebody who does this to be able to interpret, what that means. But there are. It looks like these look like gas bubbles there. But yeah, the stomach doesn't look as yeah.
With the tumor causing beta cells.
That's what's probably happening. That's what cancers do, is they suck nutrients and they physically impinge on the local cells. And so they're starving the local cells of the nutrients they need. And they could also be impinging on the beta cells and preventing them from producing insulin. Yeah. Okay. Pretty good. What do you guys think about this one? Interesting. Okay, interesting. Which one have you guys liked the most so far? Graves' disease, celiac disease, or pain in the gut?
I like the sweet one.
This one? Oh yeah, I am the sweet life one. Diabetes.